Sure. Hello, everyone. Good afternoon. Thank you so much for joining us today. I am Lisa Lee with LACMA. We have here Cheryl Bradley, the Associate Director at the CMA Center for Economic Services. I'm going to just go over her brief bio and then just a little bit of housekeeping, and then we'll have her go ahead and do the presentation. Cheryl has over 25 years experience in the Medicare program and has held a variety of responsibilities, including education and training specialist, medical review analyst, and has worked with providers in virtually all specialties across all the California Medicare contractors. Cheryl is a credentialed instructor known for speaking at conferences, state associations, and for numerous organizations. She provides problem-solving assistance to CMA member physicians on a number of healthcare issues, and she is skillful at using humor to help providers navigate this difficult program. So just a couple of housekeeping. If you all could stay muted during the presentation, that would be great. If there is time at the end, Cheryl will answer questions, but we encourage everyone to enter your questions into the chat as well. The presentation is being recorded and will be distributed along with the slides after the webinar. And with that, I'll have Cheryl take it away.
Thanks, Beth. And hi, everyone. Thanks so much for the introduction. Welcome to our 2023 Medicare updates and beyond. We definitely have a lot of information. We thank you for taking time out of your busy afternoon to join us. We know you have many options for acquiring your Medicare knowledge. Here's what our agenda looks like. Like I said, it's a lot of information. Yes, you will receive a copy. I want to make sure that you have that. Like Lisa said, in terms of answering the questions, but I try to get everything here. But if you have anything that we're missing, if it's in the chat, you can email me a little bit later on. I'll have that information at the end as well. Let's jump right in. Here we are. And I know some of you, if you're like me, you like to watch crime dramas, SVU, things of that sort. And usually if you're watching those, you'll notice that they'll show you what happens at the beginning of the start of the program. And then they work their way back to kind of give you an insight on who's who done it and things of that sort. And so I'm going to work a little bit backwards in these first couple slides because I want you to see, yay, at the end of the year, you usually see on the news that there is a congressional year-end omnibus legislation, and we needed it because the Medicare fee schedule was, right after the final rule was given, Medicare was expecting an 8.5% reductions in the physicians' fee schedule. And of course, we could not take an 8.5% reduction in your services along with everything else. No inflation built into the system in more than 20 some odd years. We just weren't going to be able to take that. So CMA, AMA, all of your other specialty organizations representing all of these physicians were lobbying, making bills and everything of that sort. And so finally we got the fee schedule down to about 2.5% cut instead of the 8.5% that was expected. The revised conversion factor is the 33.8872. The GPCI, or what we call geographical practice location, was extended through at least to the end of 2023. Remember, that's location. We'll still see a little bit of a cut in 2024, but in order to stave off all of this, the bottom line is that we're going to need payment reform. That's the ultimate goal, so that we don't go through this every year. There was an expiring bonus payment for the advanced alternative payment models that was also included in this year-end legislation. It went down to about 3.5 instead of disappearing. The intent was for it to disappear altogether, but they compromised at about a 3.5%. Also, the one thing that all of you want to know, and hopefully you're here in time, listen up, that the COVID-19 telehealth waivers are extended at least through to December 31st of 2024. That includes your payment parity, which would be your in-person visits, your audio and video. Remember all of those things that have come into effect as of 2020, and we'll discuss it in a little bit more detail. There are no restrictions on geographical practice regions or originating sites. That's why I told you we put the cherry on top, and then I'll back up just a little bit to kind of give you an idea, so that if you have seen something a little bit different, you're like, oh, they just don't have the update. So originally, the physician fee schedule was released in November. Usually the proposed rule comes out in July. July through the second week of September, usually they will field the comments from all stakeholders, physicians, association groups, that includes LACMA, CMA. We would all get involved in submitting our letters, discussing it with our legislators. And remember, originally there was a 3% statutory payment increase in the previous year. So the fee schedule, as I said before, had an 8.5% cut, because it would have had a 3%, it would have had a 4%, all of these different things that have been promised while we've been in COVID since 2020, and then they need to make good on that. All right. So a CMS policy to define the split shared visit was part of the final rule that came out in November. The temporary telehealth services, and two things that you also want to remember is that legislation is required for telehealth. And then also CMS, you will always hear, if you listen to any of their programs, you would have heard them say, oh, we need legislation to extend this. So CMS has one thing where they had voted in the Consolidated Appropriations Act of 2022 that when COVID comes to an end, there would be an extension of 151 days. So on day 152, the telehealth for some of the codes would come to an end. So I want you to remember what you see in terms of the omnibus conciliation or legislation that is passed at the end of the year before everyone disperses for the holiday, and then what would have been decided on in November when the final rule always comes up and is ready to go. Noridian has reposted the 2023 physician fee schedule with the cut of only 2.5% as opposed to 8.5%. So that should be posted for you to look at as of last week again. Also, I have a fact sheet of all of these changes, because of course we only have so long to go over them, but I always give you a reference. I believe you don't have to know everything, you just need to know where to find it, all right? So we've got to, a couple things, one other thing, and then I'll move on, is when you look at this slide, you'll see budget neutrality. And remember, budget neutrality is always that the losers have got to fund the winners. And don't forget, there was a substantial change to the E&M services over the last couple years. So for those providers who do know E&M visit, they would see the cut more than others. Those who have visits built into their practice are those who would see usually an increase in their allowances. Here we are with also a second page on your physician fee schedule. Again, the GPCI, Geographical Practice Cost Index, always comes into play regarding the location. 3% temporary increase in the fee schedule, 1.5% budget neutrality. This particular slide that you're looking at here simply explains why we originally saw that there was a 8.5% reduction as opposed to a 2.5% increase in the very beginning. So I have that explained here. 3%, 1.5% in budget neutrality, 4% in the pay-as-you-go sequester. CMA advocacy included supporting Medicare's Act of 2022 that was started by Congressman Amy Barra. And then you, as members of the association, were also even given a chance to submit your comments to your respective congressman as well. So you also want to make sure that you are definitely signed up to receive the subscriptions from CMA, so that you are always aware of what's going on and how we get to where we're going. All right, give me just 1 second. Let's see. All right, looks like somebody says they can't hear. I can hear. Okay, it can hear. There we go. All right. Some of those of you who like, we've got the fee schedule in there for you. Okay, got it. Just want to make sure I've covered those. We're on the move, everyone. Here we are with the highlights of some of the things that are going to happen in the, or have already happened in your 2023 fee schedule. Again, we said your evaluation and management services, your split share definitions until 2024, delay the penalty in appropriate use criteria. CMS is still seeking public comment on the global surgery package. They would like to go almost a la carte, but so far they have not gathered up enough data, have had enough comments. Right now, you know, the global surgery package is pretty much a given. You don't take that apart, but they would like to do that, but just haven't gotten to that point. Audiology services, behavioral and mental health, chronic pain management, remote therapeutic management, telehealth following the end of COVID-19 PHE. Hopefully you got in at the very beginning. If not, that's okay. You, again, I say you will get your copies of these slides and see that legislation has voted at least to take telehealth until the end of 2024. So you can relax on that one if that was the only question that you had. And then colorectal cancer screening has changed its minimum age from the 50 down to 45. And next to that, I even have a reference that has a couple pages. And you see that CR, you'll see it here now and later, change request 12656 is what's included. Let's look at the E&M updates. Now, for those of you who do E&M services, one thing you want to remember that this is a continuation of the multi-year effort to update coding. You saw it with the outpatient services. This particular year, they're now entering into the hospital inpatient, observation, domiciliary, nursing facility, or resident services, even cognitive impairment assessment. So that's where a lot of what they believe is relieving the administrative burden from our providers. CMS, of course, is the governing agency for Medicare, adopted the revised CPT guidelines of the AMA specialty and the RVS update committee, or what you'll also hear called as RUC. Here in the second set of bullets, I tell you what the revised coding and documentation framework includes for 2024. New descriptors, revised interpretive guidelines for medical decision-making, the choice of medical decision-making or time to select your code, and then it's eliminated the use of history and the exam to determine code level, unless it requires medically appropriate history and exam, and the clinician is ultimately responsible for that. So this kind of gives you a snapshot of that particular group or family of E&M services that are being adjusted for 2023. At the bottom of the page, I also, and once again, give you the resource to the AMA E&M 2023 guidelines. This particular resource is worth its weight in gold. Remember, we said you don't have to know everything. Again, you just need to know where to find it. Don't let this particular snapshot scare you. It just kind of gives you everything you need to know. This is a snapshot of the resource that I just mentioned on the previous page, where it will tell you exactly which codes have been deleted, what's revised. You know, I had a doctor ask me, what happened to these particular codes? I sent her the book. Here's your booklet. Here's your resource. She didn't have to come back with any other questions because it's just that good. It's about 42 pages, so you're going to need a little time to read over, but I guarantee you're going to be able to use it in your particular practice, all right? So it's going to work out for you. Here are the prolonged services that are brand new. Notice G codes, which are usually temporary, up to about HCPCS codes that are temporary up to at least 5 years if they need to be. But CMS created 3 new codes because we didn't like the description of service that was revised by AMA. And we've done that before, that if they bring out something they decide on and we don't like what they've done, sometimes we can CMS can create its own HCPCS codes in order to accommodate prolonged services. Medicare believes that all of the time needs to be exceeded before you go on to the next code. So here's the highest level of time value for your 99205, 99215, 99223, 99233. Your prolonged services without direct patient contact are invalid for Medicare. And again, the entire 15 minutes must elapse before billing your prolonged services. Do not report anything less than that. Of course, you've got your start and stop time in your documentation, all right? Remember, it's all about your documentation. If it's not written down, it didn't happen. If it didn't happen, don't bill it. And again, we're going to come out of COVID, and we're going to get into that period of time where you'll notice that your audits will pick up just a little bit, all right? Here are your split shared visits for 2023. For your E&M, CMS finalized the year-long delay of the split shared established in the rulemaking 2022. So it tells you that the professional should bill for a shared visit by defining what the substantive portion of the service is as more than half of the total time. So in 2023, the substantive portion of your visit is comprised of your history, your physical exam, your medical decision-making, and more than half of your practitioner time. Remember, whoever's billing the split shared is definitely going to be both who are sharing in the time between the physician, non-physician practitioner are going to be, they're going to be represented in your documentation. Notice the D word again with the timing. So again, it must give you who both of the individuals performing the provider, the time, start, sign off, and date. I gave you at the end of this particular slide a resource once again to the Noridian article. Remember, Noridian is our Medicare contractor for California, Hawaii, and Nevada. Remember, they're processing the claims on a day-to-day basis. So make sure that anytime you see them put out an educational article as well, that you've taken up time to go there and review it. If the split shared time is part of your practice, you may not need that, and then there won't be an issue. But if you do, you want to make sure that you see and hear what the provider is saying. All right. Looks like we've got disallowed and when. Somebody asked me about audio CPT codes. Hold on just a little bit longer. It's coming. Somebody asked me about totally opting out. Hold on just a little bit longer. It's coming. Those of you who submitted questions at the beginning, they are in the program. Stay with me. I've got a lot of good information. I guarantee you everything I give you, you will be able to use. And I'm sure that's a big guarantee, but after working with Medicare all of these years, I can guarantee it. Dental or oral health services. The final rule codifies and clarifies a regulation that Medicare payment can be made for these following instances. Dental and usual oral healthcare services are not covered by the program, but there are some instances: stabilization of teeth in connection with the reduction of a jaw fracture, extraction of teeth to prepare for radiation treatment, dental splints, things of that sort. So CMS finalized dental services also that will include both exam and treatment and should be covered prior to cardiac valve replacement. So they've got a lot of different things, valvuloplasty procedures. 2024, they're looking at reviewing the dental exams necessary prior to treatment, head and neck cancers. Those are your updates for dental services 2023. Here's your behavioral health. I don't have to tell you, you hear it all day. Different things that are going on, whether it be addiction, whether it be the homelessness, whether it be just things about mental health deteriorations. And here we are, one thing that they determined that they had to do, and they've seen in COVID and getting access to care and patients being at home as opposed to coming to the office, they've started to allow a general supervision by a physician or non-physician practitioner rather than direct. Remember, direct is you've got to be there directly available. Here with a general supervision, you don't have to be exactly right there in the room. They're really moving around some things, residents, all of that. General behavioral health integration code, G0323, monthly care integration performed by the clinical psychologist or the clinical social worker is brand new for this particular day as well, all right? Here we are with your chronic pain management. We've also, CMS also finalized your new HCPC codes, G3002 for the 30 minutes, and then G3003 for each additional minutes and valuation for chronic pain management. So they're trying to bring that back in for calendar year 2023, and they've provided some additional flexibilities, such as the ability to report the CPM and other visits on the same day, and to report subsequent chronic pain management services as many times as needed in a month. And you know, that's something definitely as many times as needed. Usually we've got Medicare unlikely edits that stop you from doing anything too many times. So that is a change, brand new in chronic pain for the new year. Opioid treatment program, definitely, and again, the access to opioid treatment, your abuse program, you know, Medicare has put a lot of money into policing these particular programs. And here this includes information regarding revising the pricing for methadone, allowing a longer therapy session from 30 minutes to 45, being able to use a two-way audio video technology, all of those things. Remember, also, even the patient has been able to be at home. That is an originating site. Remember, with telehealth, and we'll talk telehealth in just a couple minutes, originally the patient's home was not a site. So all of getting into the abuse of the drugs, the opioid treatment has allowed for a lot more flexibility. Here, even you can provide periodic assessments via audio only when the video isn't available. They've kind of shot down. Remember, there was a last year, there was a provision that you needed to have a visit at least every 12 months. They haven't been able to get that one through yet. So you still have a little bit more time. And then billing for medically reasonable and necessary services provided via a mobile unit is also something that's brand new and okay. Here at the bottom of the page, again, is your resource. For those of you who came in just a little bit later, you will get a copy of the presentation today, so rest easy. You'll be okay. Resources, again, you don't have to know everything. You just need to know where to find it. I gave you just about everything I think you need. Final rule, quality payment changes, your fact sheet. I know you don't have time to read 2,953 pages, so CMS always has a summary document that is available for you. CMA always does a summary document available, and the AMA also does a summary document as well. We made it to where a lot of you wanted me to be, and that was telehealth. But remember, at the beginning of the presentation on slide 3, I talked about the fact that payment parity, the telehealth expansion, payment parity is going to stay in place, everybody, at least until 2024. Okay, expanded the number of services, audio only, telephone is going to stay in place. I know some of you asked that question, at least until 2024. So we're still good where we're going to be. The waiver of the originating site rules and rule restrictions, again, before we got into COVID in 2020, the patient's home was not an approved originating site. And once we got into pandemic, those circumstances called for doing something different. Patient access, your offices were not open, the patients were not able to come. And so a lot of those things have come to be. Let's see, let me go back just one other piece that I wanted you to see, and that is I've got your resources for the CMA Health Law Library, CMA, your online resource center, your telehealth webinar series, and the webpage. How many of you, and I'm just saying this out loud, you don't have to raise your hand because I won't be able to see everybody, but if you can raise your hand and make you feel better, that last week, the VP, one of the VPs at CMA actually did a telehealth presentation all by itself. So remember, Cheryl is trying to cover all of this in your 55 minutes or so, but telehealth by itself is a separate presentation. Only thing I want you to remember, as far as Medicare is concerned, it has been extended to 2024, at least. Where we started in 2020, somebody asked that question, because public and private payers tend to follow Medicare during the time of pandemic, most payers using the same telehealth rules. Moving forward, now everybody listen to this. Remember, we said 2024, we're still going to be doing telehealth. One thing you want to be aware of, and you want to ensure that you subscribe to the CMA website as a member, because you want to see when we do any additional presentations, and you want to see, or it's passed down to LACMA as well, they'll put it on their website when these changes will start. Remember, you've got CMS for Medicare, you've got federal legislation that enters into this, you've got a state government that enters into this as well. Remember, California would like to stop telehealth at the end of February 28th. So you will see some changes as far as the state is concerned. Moving forward, again, the rules governing telehealth will vary by payer and coverage. So if you're doing United Healthcare, you've got some other things by Anthem, you're going to want to pay attention to the information that they send out to you. Make sure you are signed up, because they could possibly change when California begins to bow out February the 28th. The actual pandemic itself is declared and renewed by the Secretary of Health and Human Services at least every 90 days. So as a federal program, it doesn't end until April the 11th. And as we said, your payment parity, your telehealth services, for the most part, for Medicare, go all the way until 2024. HHS has pledged to give states a 60-day notice prior to expiration. So every 90 days, you would look to see if they're going to extend this and when we're going to end and everything like that, all right? So 60 days. Current resource. I've got your current emergencies. I've got your updated list of blanket waivers. And most importantly, look at that last bullet. You'll see that, and you'll be able to click on these when you get your copy. Frequently asked questions are very good and well organized for CMS. Let me see what some of my chat questions are. All right. Looks like they're making sure that you have the resource links. Audio CPT codes will not be disallowed till we get to the end, somebody asked, and then totally opting out. I will save that. I'm coming up on enrollment. All right. If you're doing the physical exam, the same way you've been doing it before, all right? Just make sure if you've got substantive services, you've got to start and stop. What does that entail between the two physicians who are splitting the time, and make sure that you have it documented as such. All right, somebody says shame on Newsom. All right, here we go. We are continuing. Here's the, we talked about your federal legislation. One thing that you'll see and hear on your news would be your Consolidated Appropriations Act of 2023. If you watch the news on a daily, you will see this come up in some shape or form because it was signed by Biden. Remember, we said we had legislation at the very end. And here's the big one that everybody asked me about, and we'll continue to see. We had it at the beginning. Here we are in the middle, that it extends Medicare telehealth flexibilities at least until December 31st, 2024, regardless of the PHE. Yay. Your originating site waiver, patient's home, of course, those flexibilities are still built in. Your payment for audio only telephone visits continues, and it extends the ability for FQHCs and your rural health clinics to provide telehealth. All right, you got it. There's the answer to your question, the ones that you wanted to see. Here's your telehealth approved services list that is updated. So the change request, I always tell you, anytime you see a CR, it means change request. That means the information that they put out for you as a provider to read and understand and implement in your practice. Here, effective January the 1st, 2023, you've got a category 1 and you've got a category 3. Remember, you had category 1 was codes that wanted to stay. Once PHE is over, they've still got to agree on that. Category 3 would be your temporary services that are allowed until the end of the public health emergency. So that's where you open up your list and you go there and you can see the actual dates that it has been added to the list and when they anticipate that those services will come off. Two things. There is a Consolidated Appropriations Act of 2023 that extended telehealth through to 2024, December 31st. And then last year, we had a Consolidated Appropriations Act of 2022 that said the flexibilities only lasted until 151 days after the public health emergency. So let's pay attention and see what our state and some of your other private payers and commercial payers. Remember, Medicare is going to go to December 31st, 2024, but state can stop, intends to stop February 28th. So you'll be on guard for what your commercial payers may say a little bit different for Medicare because they do have their own way of doing things, all right? Telehealth services continue. If you need to include the modifier, if not, leave it off. The originating site fee had an increase to $28.64 for 2023. I've got your AMA resource at the bottom of the page as well. All right. Here I just explained, and I won't stay there too long because I don't want to start to mix you up, go from start to finish, beginning and end. What I just wanted to show you was the legislation, last minute legislation at the end of the year changed the game. But before that, there was legislation in the Consolidated Appropriations Act of 2022 that some of the other payers may elect to take advantage of. But here, telehealth is still good. Geographical location, including the beneficiary's home. Remember, before pandemic, that was not so. Certain services to be furnished via audio-only telecommunications, still good. Your physical therapist, occupational therapist, speech language pathologist, audiologists can still furnish telehealth services. Remember, in the beginning of pandemic, their service codes were approved for telehealth, but that particular provider was not approved until later on in the process, probably 2021. And then lastly, I've got on there, I want to remind you that the OIG, the Office of the Inspector General, what we call the Medicare POPO, is going to look up at some point and restart the audits for telehealth services. They haven't pushed it yet, but remember, there is a 3-year discovery for Medicare. A lot of times people will say, what's the statute of limitations? How far back can they go and ask me on audits? At least 3 years on discovery, 4 years recovery, where they can ask for the money, unless it's something FBI or False Claims Act. And by that, I mean, if you've seen on the TV, sometimes we'll see a sting or something where they've been working for 10 years to bring down a particular ring that was processing fraudulent claims. So 3 years usually is the recovery time. And if your calendar is at the same place that mine is, we're in 2023, which means they're going to need to step up the audits for what year? 2020, because that's 3 years back. All right. That's all I just want to make you aware of. They probably won't do too many, but it just depends on who. All right. Let's see a couple things in chat that I've got. Let's see. Follow the same time, internet assisted telehealth. Phone console still. Let's see. I have to come back to that, Jim. Let me see. Follow telehealth. Yeah, your 99441 still audio only, still follows the same time as internet as telehealth. Yep. Consult still. You're not using a two-way and it is still good, still using payment parity. By payment parity, I mean it is still being priced, crosswalked according to your 99212 through 214. Let's see, we've got the OIG. There's a date for telehealth also in, yes. Like you said, Medi-Cal is going to make some changes. That was January the 1st. We've got the state telehealth ends February the 28th. There we go. Let's see if I got everybody else. So we are doctors. Forgive me. This is a CMA lecture. We are, do not call us providers. It demeans our work and devalues us. All right. Definitely don't mean to devalue. Only use the, forgive me, the word provider usually, as opposed to physician, forgive me, or non-physician practitioner, usually the word provider is included in a lot of the regulations because they turn to so many different people. So forgive me, charge it to my head and not to my heart. Thank you. All right, I'm on the move. Here we are, rural health clinics and FQHCs, chronic pain management and behavioral health. I've made sure that you recognize the codes and the guidelines if you are in an RHC or FQHC, federally qualified healthcare clinic situation, all right? Rural health as well has all of its resources, the different codes that may account for the same services that may be off just a little bit, may need a different code for the same service where it's processed or performed in rural health as opposed to the physician's office. Same thing, FQHC. Most of the time you see a resource from CMS as well. And here we go that we have a resource for the FQHC, all right? COVID-19 response, let's look at it. We're moving. Here's want to make sure you're updated on your vaccine guidance, the allowances. Don't forget that once pandemic comes to an end, officially, the administration will go back down to $30 as opposed to $40 per dose. But you'll definitely be reminded of those things as we get a little bit closer. But as I've told you repeatedly now, we have a little bit more time, all right? CMS frequently asked questions. That particular link is here. Your CMS provider vaccine toolkit is here as well. Your booster recommendations, everything I've given you a link because we would be here all day if we tried to have a slide for each and every drug that is approved now. So I make sure that I kind of put them in a concise order so that all you have to do is click and go to that particular resource if that's what you need for your practice. Same with updating, the patients and their flu shots in the flu season now, the average wholesale price, the allowances, all of those things, checking your patient's eligibility from your Noridian portal, your Noridian healthcare portal, you can do that as well. See if they have had the shot, of course, because your patients will not remember. That is the allowance. Your review contractors, we talked about it before, that your reviewers review a small percentage of the claims, but during the PHE, the flexibilities were supplied across claim types. Read your new FAQ about how CMS review contractors will conduct the medical reviews after the COVID-19 pandemic. So definitely that is on the schedule of work for a lot of your contractors, all right? Just want to be aware of that. Again, I said they can go back to 3 years discovery, 4 years recovery on most of those. Here's a few other hot topics. We're looking at the we're looking at the premium, the deductibles for your beneficiaries for the year. Definitely the Part B premium went down a little bit, and so did the annual deductible, right? Remember, there was Part D, the Inflation Reduction Act. A lot of the drugs went down, so there was a little bit more leeway. The cost of living allowance for your beneficiaries went up. So Part B for your physician services is on the left-hand side. Part A is on the right-hand side for the premium. 99% of your Medicare beneficiaries do not have an inpatient premium if they've worked 40 quarters in Social Security. At the top of the page, I put that base premium so you can get an idea that if you have not worked at least 30 quarters in the Medicare program, what the premium would be for Medicare hospitalization now. And then I include all of the other co-pays, nursing homes, psychiatric facility, inpatient deductible, etc. Here is the Medicare preventive services. One of the questions, a lot of things that are included here. You can click into this resource sheet and it will tell you the services. It will give you frequencies, diagnosis information, and everything. It is a live link at the top of the page when you receive your copy as well, so that you can include, get the Medicare preventive services. One of the questions was Medicare does not cover regular preventive skin or melanoma screening. No, however, Medicare can cover the different services that are, the different visits that are associated with skin cancer, things of that sort. Usually you already know if there's some type of symptom, is there something they see, is there some type of history to rule out or diagnose. Those services are definitely still covered, but you will not see a melanoma or skin screening topic included in the Medicare preventive services guideline that I'm giving you here. Audio only, yes. Tasha, those codes are correct. Jump to the first unread one, let's see. I'll come back to you in just a minute. Audio only, 93.95 for telehealth. You've got it. Thank you. Anybody else? All right, got it. We're coming down. Okay, let's see. I was told audio only telehealth is only billable the last falls in within 6 months. Is it correct? No, they haven't pushed that. Somebody asked about the audio only 99441, 99442. You can even use those for new patients now. Remember at the very beginning, in 2020, the fight was on that it was only for an established patient and it had other guidelines, but the flexibilities have been extended, all right? Let's see. And let's see if I've got one more. All right. We got those in. All right, let's see. Let's continue. Next up, remember your patient's advanced beneficiary notice of non-coverage. Remember, that's if you have services that may or may not be covered for the patient's reported condition. Want to make sure that you have that talk with them before the services are rendered and let them know of their liability. Complete the form. One thing that I want you to remember more than anything else is this is not a blanket waiver, so don't give this form to everybody else. When you use the advanced beneficiary notice, do not change it for your particular practice. You can put your name and everything on the top of it, but don't alter the form or it will become invalid. And then thirdly, one thing I wanted to remind you of is that this particular form expires in June 2023. We should be on the lookout for a new form. I have not seen it yet, but we've got a little bit of time. For those of us who are paper pushers, you know, if you like to use the same paper, make sure that you always go out to the website and look for the newest and updated form. All right, here we are. Updates with your CPT. We've got a lot of updates in terms of editorial changes, new codes, deletions, revisions. We have visited a lot of that since the beginning of the webinar. One thing I wanted to remind you is that CMA has an education event and the link is live at the bottom on February the 9th, 2023, where you can go out and click. We are bringing in a professional coder who has her own company, Lynn Handy. We've worked with her for many years now. She's going to come in and she'll go over a lot of the changes. She's already done the evaluation and management. So hopefully most of you are signed up to subscribe in one shape or form and that you actually look at and read them, because she just did this update on the E&M services last week. So make sure that you're getting the opportunity to get your educations and get some of your other questions answered. Next up, ICD-10 is, we've got over 79,000 codes. They're adding more and more every day. You saw with pandemic, they've had to add a lot of codes in terms of long pandemic, post-COVID, current COVID infection, all of those different things. And so again, a lot of changes. ICD-10 substantial for this year, 42 new codes as of April the 1st, 2023. And then once again, Lynn is going to do an education session for ICD-10 as a professional coder for the organization, February the 28th, 23. So you want to definitely sign up for that one. Here's the chronic care management services. I had a couple questions regarding that. I think someone asked me, do we think this is the new standard? Definitely, I believe that CMS has been trying to push that this is a standard in terms of access and value-based care. The one thing is that there are a lot of elements in the chronic care services, and they have seen that the documentation has not been good. So they're pushing providers to use this service, definitely in primary care, but the documentation has not been good. So therefore, you use a service that you create another error. You've got to do it right and you've got to do it well. all right? So I put those codes here. I put this particular booklet that is indicated has beneficiary eligibility, provider eligibility. You're providing your documentation, expectations, and then any pricing and any payment. And then I think one of the questions was also asked regarding a nurse ran corp. And I think as the doctor told me earlier that we are a physician organization, the nurse getting into the first position, I don't think is the intent, not yet. So the resource is indicated. Again, don't have to know everything, just need to know where to find it. Here on this particular page, we've got a lot of updates. I didn't try to put them on separate slides because there are things that happen and are updated quarterly. So in the left-hand corner where you see that CR, especially for something like, let's say, NCCI edits. Remember, those are your bundling edits, B15, that you would see on your claims if you've got some type of bundling discrepancies that would not be the patient responsibility, but would be up to the physician's billing staff to correct. That is indicated here, all right? So these are your revisions for January, and then you will see an update again for April. The quality payment program. Remember, it was created by the Medicare Access and Chip Reauthorization Act of 2015. So we've been in a little while. It was promising that it would be a pay for performance program, and that a lot of your patients would see some type of outcomes. That's what they were looking for, outcomes here. The providers would be eligible for bonuses, the accountable care, alternative payment model, whatever the case may be. So that is what this particular section kind of looks over. It looks at, for those of you who still deal with MIPS and MACRA, it reminds you that the submission window is open until March 31st for 2022. If you are a provider who has some type of extreme and uncontrollable circumstances, don't believe that you can submit data, there is an application that you can actually fill out. So I have that here. If you are a provider who believe that you are a small organization or physician with a small organization practice who does not bill MIPS and MACRA, you can do that one here as well. All right. It also looks at your eligibility. So if you are a physician practice with less than 90,000 in Medicare payments, you see less than 200 patients, then you are probably exempt. And so you can put your MPI where I said check your initial 2023. You can click on that one, put your MPI in that status to and verify that you don't even have to participate in this particular program. Here's the Medicare value pathways. Remember, in the very beginning, 2015, a lot of organizations, physicians, and everyone else indicated that they were supposed to participate in MACRA, but they couldn't find the 6 quality measures. We have finally gotten down to where CMS is, okay, we heard you. We are telling you what we believe is the pathway that you should follow in order to be successful. So they had 7, they've added 5 new ones. They also have that they have 5 new candidates for 2024, and they are taking feedback on that one at the end of this particular, up through February the 8th. And so the link that I show at the bottom goes over feedback for what the new ones are going to be. One of the new 5 includes the women's wellness, some things of that sort, all right? Here is the new updates, the new scoring. The performance threshold is up to 75. Exceptional is set at 89. Data completeness increased to 75%. So by now, remember we said 2015, we are 8 years later, and they believe that a lot of the physician practices that are going to participate should do pretty well now. And so it will be harder and harder, you'll see, to get a pretty good score and the bonus information. Updating the measures is on this particular slide for you. Here are your resources, a phone number to the service center in case you need it. Here's Noridian, your MAC compliance. We're coming on home. Here is your self-service tools, verify your eligibility, check your claim status, print your remittances, reopening, submit your appeal, overpayment results. Remember, just like every place else, the bank, the market, those things that allow you to do it yourself, Medicare also has its number of self-service options that you can do 24/7. Providers, here we are also on enrollment. One of the biggies always for Medicare, revalidation has restarted. Because we were in pandemic, usually the provider revalidates every 5 years, but because we were in pandemic, there was a waiver for 2 years. So if you have not revalidated your practice, you should be receiving a letter if it's time. The middle of the page says you can click on that data.cms.gov and you can see if you are due to revalidate the information in your enrollment file. You can do that yourself. Again, self-service. Your general updates in that CR 12880. Remember, ownership disclosures, electronic funds transfer, if you change your banking information, if you change any of your special addresses, all of that is regulation as far as as far as your enrollment is concerned. Don't forget, you've got to keep that updated. Even if you're in the same building and you move from suite 300 to 200, that is a change that is required in your Medicare enrollment. And I have on the right-hand side the number of days that you are given to ensure that you get that information updated. 90 days to report. You can use paper or the internet-only PAYCOs. You can send an email with questions, your PE education at Noridian. I, of course, represent CMA. So if you have issues with your enrollment and you haven't been able to penetrate the walls at Noridian, I am available to assist you as well. All right. And somebody asked me, I put it on the left-hand side of this slide. You will receive them again. Ask me about opting out. You can only opt out from Medicare during open enrollment. And we are in January, which means you are just beyond that time period. Normally, it starts the second week of November and goes down until December the 31st. So we have already bypassed the open enrollment time. You would have to look again if you want to opt out. It would not come up until usually November through December of that same year. All right. So that was one of the questions that was asked. Here we go. Auditing. I'm almost home, everyone. Auditing again, the targeted probe and educate, where they ask you for 20 to 40 charts. They get them, they read them, look over them, have medical review, and they immediately respond to you regarding what they see and how you can improve. You get 3 rounds of the prepayment review. These next 2 slides show you those services that are targeted as pre-review on the list. All right, so post-review. It's the targeted review program. And these services, some of them, even a 66984 is a targeted one on the list. Those of you who do the initial annual wellness visit and the subsequent visit, I want to point out that, again, that is targeted on the list. They have not seen good documentation, whether it been with Noridian, the Recovery Audit Contractor, the RAC, the OIG, Office of the Inspector General. All of them at some point are touching this exact same service because they do not like what it look like. Remember, even with telehealth, this one is still on the approved list, and it has some services that a lot of providers ask, well, we can't weigh the patient. We're just going to have to go with what they say. A lot of services that they are still looking at, all right? Provider compliance tips is there as well. Avoid cloning. The copy and paste. Now, we know you will. We know you save time. We always do it. But the only thing you've got to ensure is that your EHR has prompts so that the information that you put in there definitely changes it. You're not copying and pasting from a he, and then it comes out she, and it has always done that. If we talk to Dr. Lurvy at Medical Review at Noridian, they are always catching someone because they have that issue with copy and paste and cloning. So I just did a reminder to make sure that you update or amend to reflect the status of the patient's condition at the time of the current visit. The physician is the only one who knows the patient, and the only way they can determine medical necessity is if they pick up your documentation, and they are expecting that it will look pretty good. This is a list of all of the entities that are able to audit your claims from Medicare. This is an entire list. At the bottom, I've given you a resource for the AMA payer audit checklist that you can use to your advantage. Noridian education events. Remember, there is no such thing as I didn't know. You must be a great Googler. If you can't find it, reach out and ask us. We have the resources. Been with Medicare for years. I work for Noridian. I work for Palmetto. I work for NHIC. I work for Transamerica. So I've got some friends. If you need some help from us, you've got to ask for it before you get too far in. We've got attorneys, we've got law, we've got just about everything you know that are benefits of being a member of the program. They are all still alive and well. Here's your appeals. You're not satisfied with the way the claim turned out, make sure that you request an appeal on it and request your appeal timely. Again, if you have issues, ask us and we'll ask a few friends. I have the resource even on how to submit your successful appeals. All right. See, all right, I'm at the end. That's it. We made it down to the end. Here's your resources. Here's my information. Let me look and see if I had any other questions. Jump up to the top. All right, Lisa put there, what about extensions from home, health orders, in office visit, or telehealth? Still okay. All of those things are still okay. They haven't changed those waivers yet.
Can we ask a couple of questions?
All right, come on, give me 1 second. Daniel did ask me about 99441. Remember, if you're using the telephone in telehealth, use the 99441 through 99443. It will price as a crosswalk to 99212, 99215. They are not in the office. All right. Okay. I'm ready for your question. I'm listening.
Yeah, thank you. You know, I'm not entirely clear about the opt-out. I do want to opt out from Medicare.
Okay.
And this level of complexity, it prevents really for us to practice medicine. And I'm going to be applying is after that enrollment period. How long would it take to become effective? I talked to Medicare actually, and they said the date your affidavit is signed is the date that your opt-out date will go into effect, but I am not sure if the person gave me the right information or not.
Usually the opt-out, they will look at your affidavit that date, but it usually is effective for that following year because you can only opt out during the open enrollment. So from November, like you said, to December, and usually it would become effective that following year. So let's say January, since you didn't make it for 2023, let's say January of 2024, it would be effective.
During this time, we can still have an agreement with the patients, or Medicare will continue to pay us? How does that work? I don't quite understand it.
The question, okay, so your affidavit and your agreement is only going to come after Medicare has sent you a letter and said, we approve you opting out. Until you get to that particular point, you don't have an affidavit that is valid with the patient, right? You've got to send in your letter that says we want to opt out. Medicare has got to acknowledge that they have received your forms and that they are going to end date your participation with the program. That's what they're looking for in that affidavit, when they'll put an end date on your provider file. So before then, any type of affidavit or private contract you have with the patient would not be valid until they acknowledge, we got you.
Is interesting, but when I looked at the website under the opt-out options,
Okay,
this type of language is not there. I don't know if they have changed it. I used to hear that, yes, you opt out between, November and the end of the year, but it looks like they might have eased up some of this language. I didn't see any limitation of this nature.
okay, so no problem. Do me a favor, Dr. Rabab. Take my information and
Yeah.
we can work one-on-one.
Okay, I'll go and send them the, the lady who was on the phone, again, I couldn't quite trust what she said. She said, no, the date is the date that you actually have your application. And then it takes about maybe anywhere between 30 days to 100 days for them to respond. But retroactively from the date you filed it, then they would say that. So I called I have 5 patients under Medicare. I told them, look, if you want to see me, you need to see me before I send out the application.
Got it.
Okay.
And that's what I'm saying. I understand. And that's why I said, make sure Lisa will send you my information again, and you'll contact me one-on-one, and I'll make sure that you understand. And if we have any further questions, I have access to my liaisons, and we'll get you a written response that you can
Okay.
get
Yeah.
behind. All right.
I'm a member of the CMA. You may I ask you work for CMA or you work for Medicare? I couldn't quite say.
I am the Medicare specialist, and I work and am paid by CMA.
Oh, okay, got it.
All right.
Very good. You have helped me in the past through email. I'll send you an email again.
Yes, I have. I was
Yeah.
going to say that, but I thought I would wait.
Yeah, no, thank you so much. Okay, I appreciate it. You guys have a
Yes.
wonderful day. Take
You
care.
do the same. Yes, you will
Bye.
receive a copy of the presentation, everyone. All right, Lisa, it's on you.
All right.
Thank you so much. Bye now.
If there are no more questions, we'll go ahead and end the webinar. Thank you all for joining this afternoon. Again, the presentation and the recording will be sent to all the registrants later this afternoon. Thank you very much and have a great afternoon. Thank you.
Thank you.